Hello, I am Dr. Paula Schreck. I'm a pediatrician and a lactation consultant, and I would like to invite you to learn a little more about the Baby-Friendly Hospital Initiative by viewing this short video. The Baby-Friendly Hospital Initiative was born in the 1990s like many other global health initiatives in an Italian palace, the Innocenti Palace, outside of Florence, Italy. The 10 steps to successful breastfeeding were produced and adopted by participants at a World Health Organization and UNICEF policymakers meeting co-sponsored by the United States Agency for International Development and the Swedish International Development Authority. Over the years, the World Health Organization has adapted their overall guidelines for the iconic 10 steps, but the basic framework of the 10 steps has remained surprisingly unchanged. Let's briefly run through the 10 steps. The practices included in the 10 steps to successful breastfeeding reach beyond the hospital walls to encompass the prenatal, hospital, and postnatal space. The 10 steps do not just apply to breastfeeding dyads, but to all birthing people and babies. The 10 steps transcend bias to assure that all birthing people have the education they need to make informed choices on their care and feeding. Once the choices are made, the 10 steps assure that the best practices are available to birthing persons, and regardless of their choices, their care is safe. I like to think that the 10-step practices start with step 3, beginning in the community, in the prenatal clinic. The World Health Organization, in its rationale for step 3, contends that this requires prenatal entities to educate on, yes, the benefits of breastfeeding, but also on the evidence-based practices that support it. Families learn that despite the widespread marketing by the industry, formula has risks. Prenatal discussions on the management of breastfeeding create a population of confident and committed birthing persons, leading with step 3, emphasizing the engagement of birthing persons and families builds a successful foundation for cultural change. Birthing persons enter the hospital prepared and wanting the evidence-based practices that we're offering, fully informed of their feeding choices. The admitting nurse and provider should not be the first people to tell families about the benefits of breastfeeding and the practices that support it. Step 10 also reaches into the community and calls for the coordination of the birthing center and the community resources upon discharge. Coordination requires mutual awareness and understanding. The community support agencies must be aware of what you, the birthing center, is providing. In addition, the birthing center's staff and you as the provider must be aware of what is offered in the community. An optimal discharge plan should be comprehensive and include home visiting options whenever possible, in addition to access to grassroots culturally sensitive birth and breastfeeding organizations. The referral should be warm, with the agencies notified so that a connection is made. Now, let's venture back into the birthing center to examine the key supportive hospital practices. In the hospital, birthing persons and babies experience no delay, medical condition permitting, in meeting each other with immediate skin-to-skin. This applies to all newborns, barring medical issues, not just breastfed newborns. This is step 4. And the skin-to-skin lasts for at least 60 minutes, which means that the first feeding should be allowed to continue until the baby indicates they are done. All routine procedures, including nursing assessments, baths, medications, blood sugars, weights, are delayed in the term, asymptomatic infant. Skin-to-skin is possible after C-section as well, sometimes in the OR, but often in the recovery room. Remember that medical necessity trumps skin-to-skin. Infant assessments on the warmer may be necessary. Birthing persons may be medically unstable or under general anesthesia. If this is the case, skin-to-skin should be initiated when infant is stable and the birthing person is responsive and alert. This may be in the recovery room. Step 7 assures that birthing persons and babies continue to stay together 24 hours a day with the implementation of rooming in, so that bonding and breastfeeding are facilitated by proximity. Rooming in means that all routine procedures, including hearing screens, are done in the room. Who would deny this birthing person the opportunity to comfort their infant during this procedure? Step 8 assures that infants are fed on cue, not on a schedule, an approach we now like to call responsive feeding. The Academy of Breastfeeding Medicine's model breastfeeding policy protocol recommends that breastfeeding infants be put to breast a minimum of 8 to 12 times every 24 hours, with some infants needing to breastfeed even more frequently. The length of feeding is not limited. At my facility, we like to say 8 or more in 24. This includes the first day of life. Birthing persons are taught to recognize early feeding cues. Birthing persons are assisted with position and latch by trained lactation and nursing staff if necessary. The standard for baby-friendly hospital initiative is that assistance is offered for the first feeding and again within 6 hours, and feedings are assessed moving forward once per shift, including on the day of discharge at a minimum. This is the spirit of Step 5. And dyads with special needs are given special help and are supported by individualized feeding plans. Exclusive breastfeeding is promoted and protected as an achievable goal. When infants require supplementation for medical indications, Step 6 assures that hand expression of milk is a skill that is taught to all birthing persons to allow for the use of the birthing person's own milk as the first choice for supplementation. And ultimately, if the infant and birthing person need to be separated, pumping or hand expression is facilitated as soon as possible, preferably within 1 to 2 hours of separation. Note, whenever possible, separation should begin after skin to skin. For families that choose formula feeding after making an informed decision, their choice is respected and they are taught about hygiene, safety, and proper feeding methods before discharge. Which leads us to our last patient-facing step, Step 9. Families are counseled on the use and risks of bottles, artificial nipples, teats, and pacifiers. These entities are not banned from the birthing center, but are used with caution, optimally in full-term infants with well-established latches. Well, there you have it, the spirit of the 10 steps to successful breastfeeding. Whether your facility is baby-friendly or not, are you, as a provider, promoting these evidence-based practices? Baby doctors, are you doing your exams in the room, for example? Can you influence your peers to do the same? Are you assuring that you are following policies that promote the use of birthing person's own milk or pasteurized donor milk when supplementation is required or requested? Laborists, are you facilitating, protecting, and promoting skin-to-skin immediately after delivery? It's vital that in order to reap the benefits of a supportive hospital environment, practices need to be hardwired into the workflow of the birthing center. Again, this is where you, as a provider, can be a powerful force in breastfeeding promotion. Does your birthing center have an infant feeding policy? Is it up to date and inclusive of the 10 steps? Indeed, having a comprehensive and compliant feeding policy is step 1 of the World Health Organization's 10 steps to successful breastfeeding. Step 1 does ban the acceptance of free formula samples and supplies, including gift packs from formula companies. Breaking the cycle of the inappropriate marketing technique started as early as 1959 that has provided free infant formula to hospitals worldwide at low or no cost, using provider and staff images to promote the formula as the preferred method of feeding. It has been proven that giving out formula gift bags, coupons, and samples decreases breastfeeding continuation and increases infant mortality in communities. Do you know if your facility is accepting these formula supplies? If so, what can you do about it? Step 1 also encourages hospitals to develop data gathering systems and reporting practices that assure that improvement efforts are responsive to data. You must know your starting point, you need to know where you're going, and you need to be able to track your progress. Do you know if your facility is collecting data on breastfeeding? Have you seen the recent data? Is that data stratified by race? If you can't see the disparities, you cannot work to address them. This is a lot. Even though there are only 10 steps, there are over 80 quality improvement projects embedded in the programming. And the 10 steps must not be found only on a poster in the hospital lobby, but in every room and every interaction. Staff must possess not just knowledge, but also competence and skill. The World Health Organization guidelines recently shifted to a competency-based model for both providers and nursing staff, with ongoing monitoring and education built into yearly educational cycles. It is no longer acceptable to leave lactation to the lactation service only. We all must be skilled and make skilled contributions. You may be thinking, does the baby-friendly framework improve outcomes? The evidence suggests that it does. This systematic review of over 60 studies in the world, published in all languages, looked at interventions across several environments to improve breastfeeding outcomes, including patient education, hospital policy, and community support. The authors conclude that according to the nature of interventions, baby-friendly support was found to be a significant health system intervention. In fact, among the studied interventions, the Baby-Friendly Hospital Initiative emerged as an intervention with the most potential to promote and protect breastfeeding, particularly in developing countries. You may be thinking, why can't we just implement the 10 steps without designation? Well, designation matters. This study out of Brazil in 2016 looked at over 22,000 births between 2011 and 2016 and examined the likelihood of breastfeeding within 1 hour of birth. The researchers in this study directly compared designated hospitals versus non-designated versus those hospitals in the process of designation. You can see the progression in odds ratio with the likelihood of breastfeeding within 1 hour more than doubling with designation. Quite frankly, independent implementation with self-monitoring and reporting is not the same. You may be thinking, can we do better to address breastfeeding disparities? We must. Although our overall breastfeeding rates in the world have improved, it is the disparities that persist, contributing to the allostatic load of poor health in the under-resourced in every one of our countries and regions. A social justice lens is needed. In the U.S. state of Mississippi, extraordinary work was done using baby-friendly designation as a backbone in partnership and solidarity with the community. Disparities in breastfeeding processes and outcomes in the under-resourced Black population were narrowed in addition to trends in overall improvements. I have one more question for you. Is your hospital baby-friendly? If not, why not? By choosing to watch this video, you have proven your potential to lead. As a provider, your opinion matters. Take this question back home with you to your facility. Why are we not baby-friendly? This picture of a 12-hour-old infant taken in Detroit, Michigan reminds us that although we are on different regions of the world and are defined by the unique challenges in our own communities, we share the passion of bringing the joy of health to every infant and their family.